Hi, everyone. Here we are with Chapter 5, which is Client Assessment and Diagnosis. And these are the chapters you will listen to from Read this week, so Chapter 5 and 6. So we'll start with the presentation for Chapter 5. Assessment and diagnosis is really important, so let's talk about the learning objectives. And those are really good to help you to remember, what am I supposed to get out of this chapter? When I'm done reading and listening to Dr. Veal's lecture, what should I know? What is assessment? How do you do it? What are the appropriate guidelines for it? What is our commonly used diagnostic system? We use a manual called the Diagnostic and Statistical Manual of Mental Disorders. There's been 5 editions of that. Number 5 is where we are currently, and that is what we use to diagnose our clients and then be able to describe the biopsychosocial assessment and diagnosis process. That's what we should have done when we're done with this chapter. So assessment, it is multifaceted. And what does that mean? It's ongoing and it's multi-layered. There's multiple ways you do it. And we've talked about it already in previous lectures of mine and in class. So there are different ways you gather information. So it's like the intake, right? What's going on, their history, what are the current problems, strengths, skills, and benefits of counseling. So there are different types of assessment. There's a systematic assessment, which helps us to understand the presenting problem, conceptualize the issues. We talked about case conceptualization in previous classes already. And how am I going to match the conceptualization of the case with effective interventions? Interventions, again, are techniques and the things we do with the client. How do we effect change? Relationship and positive regard, those are actually interventions. Unconditional positive regard, empathy, the relationship building skills as an actual intervention you can list in your treatment plan. But then what? What is your theoretical orientation saying to you about how you're going to use effective interventions to help meet the client goals? And then how in the world are you going to evaluate that you're making progress? How are you moving forward? How are you making sure that you're meeting those goals and objectives that you've set in your treatment plan? So definitions, important to know. Assessment is any systematic method of obtaining information from tests and other sources. You're inferring information about people, objects, or programs. Appraisal and assessment can be used interchangeably as both processes are formal and informal, not just standardized. So we talked about there are actual formal assessments like a back depression inventory that you would give to assess for depression, but you would also have more informal techniques like the session and what the client is saying. Psychological test is an objective, standardized measure of behavior usually used for evaluation. Psychological testing is a method used by counselors to collect information. So we've got methods of assessment. Here are the different methods. Standardized test, checklist and rating scales. The average childhood experience scale is kind of like a checklist. So there's a symptom checklist. There's checklists with you, and DSM is essentially a checklist. The DSM-5, when you're looking for a diagnosis, you're kind of looking to see which one of these symptoms do they have or not have. It's akin to a checklist. The clinical interview, that's your biopsychosocial, your intake, you're talking to them and finding out data, and the qualitative methods as well. Qualitative is not quantitative, it's the opposite. It's the assessment of what someone is saying. If you did a qualitative study, you'd be looking for themes in the data. Brene Brown is a famous qualitative researcher. She looked at shame and vulnerability. When she's talking her TED Talk, she's referencing qualitative methods and finding those themes in the data. So she's coming through data, but she's coming through words, looking for themes. Standardized tests are just like what they say. They have, they've been validated, right? So like a standardized test, like the GRE, right? The CPCE that you're going to take, the National Counseling Examination for Licensure. They are looking for what kind of knowledge you've gained in the program, right? And they've been, they're valid and reliable. So they have validity and reliability. And I don't know if you, let's see, get back here. So let's talk about validity. Let's move on. I was going to say checklist and rating scale. So this is going to be, if you're following along your text on the page at the bottom of 129, there are different types of symptom checklists, like I said, that are utilized quite frequently in our field. Um, they just give us, I use the Holmes and Raw stressful life event scale in my dissertation, and it was a checklist just of the stressful life events you had experienced. So they're subjective estimates of your own behavior, observations made by you, someone else, or by the client. Some are standardized, such as the symptom checklist, which is SCL 90, and and there's a brief symptom inventory as well. It's a little bit shorter. These are used a lot of times when you're meeting with your client in the intake. They're great ways to get data to figure out how you're going to write your treatment plan. And there's some examples here. There's other inventories as well. There's so many different tests. There's also the NEO personality test, and that assesses the big five personalities: extroversion, agreeableness, conscientiousness, emotional stability, and neuroticism and openness. And then the Myers-Briggs, some of you may have taken that. It's the work of Carl Jung and Jungian theory, and it's the most widely used personality inventory. I think I'm getting ahead of myself. But you see an example of that in 5.1, and some of you have probably taken the Myers-Briggs. I think you might take that with Dr. Powers. Here we are right here. I kind of got ahead of myself, which is one of my favorite things to do, right? Here it is, extroversion, agreeableness, conscientiousness. Now I'm going to check and see if we can take it for fun. I think Dr. Powers has you take it in IA. But just right now, what I'm using for fun, and I think I'm going to have you guys do is, and most of you may know your Enneagram already. I don't know that this has been validated and it's scientific, but it sure is fun, and it does really lend itself to helping people to understand themselves a bit. So the Enneagram is a little bit similar to this at this point, and clients are real into that. So that here we go. There's the MMPI. This is really, I'm almost positive that we cannot do the MMPI. There was some legislature that came through last year in the past couple years, and LPCA is such an instrumental part of advocating for our field. So kudos to them. They were trying to take away diagnosing. We just got diagnosing in our field. We were not allowed to diagnose until maybe 3 years ago. I can look that up just to give you a secure date, or you guys can look it up. Actually, I'll look it up and tell you real quick. Hang on. Here's the actual law on the LPCA website. To amend Title 43 of the Official Code of Georgia relating to professions and businesses, so as to provide that professional counseling includes diagnosing emotional, mental problems and conditions, to clarify that LPCs, social workers, MFTs are not authorized to conduct psychological testing. There it is. To provide for legislative findings and intent, to provide for a curriculum of continuing education related to diagnosing, to establish blah, 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 blah. Let's see. Of psychology, to clarify that psychological practice psychology. So here's the thing. We cannot do psychological testing in Georgia. We can do testing to provide a diagnosis, but the test for the MMPI requires specialized training and is usually used in conjunction with a formal assessment for a diagnosis for psychological testing. So if you referred a client for a psychological test, as LPCs, we're really not supposed to be doing that. I don't even do the ADHD evals. I think I'm always wanting me to, because I'm not a psychologist. I have a PhD in counselor education, supervision, and research. So these are important things to know and understand, but even a couple years ago, we couldn't even diagnose. And so luckily, LPCA helped us and got that for us, and now we can diagnose. We had to do a diagnostic impression before. But there's still some interesting language with the testing, and they went to bat for us big time. They had somebody at the Capitol every day. So if you're really interested in advocacy and leadership in our field and advocating like for us to have Medicare, we don't take Medicare yet. But this is one of those things with that testing. And when we go to conferences, when we go, hopefully, fingers crossed, I mean, may have to attend virtually this year to our state conference, but they have meetings and they update us on all the things going on in the field, and they talk with us about, um, things that are changing or evolving in our field. So really, really important stuff for us. All right, we talked about Myers-Briggs. Clinical interviews. There are multiple kinds of interviews, and we've talked about this. There's intake interviews, structured clinical interview, semi-structured interviews, unstructured interviews, and the mental status examination. So who knew there could be so many kind of interviews, right? So there are intake interviews where we're getting information. There's structured interviews and semi-structured interviews and unstructured. So a clinical structured interview is where you have a sequence of questions that you're asking. They're usually diagnostic like the DSM, or descriptive. They can be very helpful for time, but also can be really limiting for your rapport building. Um, Semi-structured allows for you to do the same thing, but maybe more flexible in the way that you talk with the client, allowing the client to talk more and not being so rigid with the structure. And unstructured is even the most flexible. You might not be able to cover all the questions, but it definitely lends itself to more rapport. Um, it's also more likely that you will maybe focus on things that are not helpful in getting your answers. So I find a semi-structured to be quite helpful when I'm assessing clients. I'm very much aware of like what they're saying, how much they're saying, and how I know how to bring them back and get my questions answered. Well, the most important thing on here is the mental status examination. It's been used for over 80 years. This is how we assess client functioning. It can be formal or informal. There's an example of what you ask in a mental status exam on page 132. They're figure 5.2. Very, very important. In fact, on the Veal Group notes, there is a column on the left and top that covers a good chunk of these. And every time we're assessing client, there's a mini assessment on my note. So I'm not only am I organizing my note in an EMDR treatment note, do I have an EMDR treatment plan, but I have a mental status exam on every note. So if their mood is different, if their speech is different, if their thought process, their cognitions are different, if their appearance is different, I note that. And it helps me to look back and say, oh, there was a huge change today, right? When the client came in for therapy. All right, qualitative methods. I hate it. I can't see that. Like that little framey in here. This we talked about it. These are qualitative methods. We're getting data, but they're not quantitative, and they're fantastic. There are card sorts, like the values card sort. Creative activities like drawing, timelines, and genograms. You're going to learn that with Dr. Muller. Any kind of exercises, other open-ended approaches, and things such as that. So really, really helpful. So there are purposes of these assessments. Clearly, these are important, and there's a reason why we do them. We collect data and figure out what we are going to do with the client. It also helps the client have a part as well as the clinician in treatment planning, and helps us to understand how we're going to put interventions and what we're going to do with the client, how to evaluate and make sure that we're doing what we're supposed to be doing. What do we contract to do with this person? We have to be trained in anything that we utilize or use unless we don't need specific training. I talked about this already. Some are only sold to professionals who meet certain requirements, like I think MMPI. In fact, let me look that up just for fun. I'm pretty sure that you have to be a psychologist to do MMPI, but hang on a sec. You won't know I'm hanging on. Here it is here. The MMPI should be administered, scored, and interpreted by a professional, preferably a clinical psychologist or psychiatrist who has special training in MMPI. So this is what I'm talking about here. This is more of something that you would do in a test for forensics or some other organization. We did them at Counseling Services. Dr. Dunlap would do a psychological evaluation on, we had sex offender treatment there, and this would be part of the battery of tests. And there was a ton, there's all these scales, but there's a ton of testing that he did to do a psychological eval for those sex offenders when they transitioned out of prison. And yes, I used to counsel them. Talked about that a little bit. Okay, let's see. All right, which I think makes me really like a tough girl because I did that and I worked with felony drug court. But anyway, diversity considerations, you have to really think about this because there are major issues with diversity with these instruments. Most of them have been validated on particularly maybe a white population of certain background. So also remembering how Black and Hispanic and other races may feel about um, testing and assessments and things like that. And um, we talked about that some, I think, in chapter 3 on this for this, and I just taught about it in addictions. So we're talking about treatment and different marginalized populations. So this is where we are now, and really important to always keep that in consideration on how you select your instruments. You got to make sure that it's appropriate and written in the preferred language. I talked about the influx of Korean patients for DUIs in the substance abuse class, and we didn't have any Korean materials when they came in, and most of them did not speak English. This is when Kia came here, and I don't think anybody was prepared. Their laws are different, and the intake of alcohol is very interesting culturally. Um, and people who are business and higher educated have more issues with alcohol. So I think these executives came over and they were drinking and driving. So it was really terrible because we didn't have what we needed to help them at the time because we had, because I've never had a need for Korean instruments for assessments at that point. So that kind of thing can be really problematic if you're not prepared. All right. Hey guys, diagnosis is a really important part of what we do. We have to be skilled at it and understand it. That, in fact, even KCRAP in 2016 required that accredited clinical mental health counselings provide evidence that students understand the diagnostic process and can use principles and practices of diagnosis. Um, and this is a hot topic because a lot of people who practice don't love diagnosis, including me, your professor. But it's important and you got to have it, and I got to have it to build. And so you got to know how to do it and you got to be good with it. Dr. Powers is going to do a great job teaching you about this. This is one of her favorite things. And so she's a diagnosis professor. And so she teaches this because she's so good at it. And you're going to really understand it when you finish how to do it. But it's not judgmental. It's a way for us to describe what's going on with the client so that we can get paid and they can get the treatment that they need. If they have the wrong diagnosis, then they could get the wrong treatment. We don't want to do a type of modality or apply something with someone or give medicine to someone who is the wrong thing. So very, very important, and often can help in assisting primary care doctors and nurse practitioners and others in the community on how to help. So when you refer for medicine, because it's going to be really hard for you to get a psychiatrist, it's kind of a dying field. Um, I think we have one in town right now. You can get one at Pathways, but right now for things like depression, anxiety, symptoms from PTSD, even bipolar. Although when we get more into bipolar and some more diagnoses like that, I do often want at least a psychiatric nurse or psychiatrist to take a look, a specialist, because their meds will be more complicated. But for sure, your diagnosis and your input will be valuable to the medical person who does the prescription for them. And very important, the DSM, when they wrote the new one, You can only imagine the controversy. I think I may or may not have shared with everyone that I wrote my dissertation during the transition from 4 to 5. So if you want to talk about something challenging, try to write a dissertation on something that's evolving and changing, which was the PTSD diagnosis. And yeah, so I had to use different measures and a measure that was not even validated yet. Yeah, yeah, but that's for another day. So anyway, now we have to do some five. So we're many of these diagnoses are linked to inventories like the Beck Depression Inventory, Beck Anxiety Inventory. There's PCL5, which is the post-traumatic stress inventory. Um, I'm trying to think what else we use. There's so many different ones, and a lot of them are free. The Eureka, the stages of change. We talked about um, the stages of change with Prashka and DiClemente, and how do you make a change? And that model, there's an assessment called the Eureka that assesses for stages of change in substance abuse. So you got to be skilled and you got to understand this. When we do that, we are accepted and we're less vulnerable to a suit, a malpractice suit. So if I say that you're depressed and this is the plan that we make to help you, and market myself as EMDR and I'm able to back up what we're doing and it's working, I'm going to be able to get paid. Third party reimbursements are insurance, other organizations that you have a contract with who are paying you for services, Harmony House, churches, the court system, the Victims Advocacy Fund are all things that pay the field group, in addition to a multitude of insurance panels. But you got to have this and share when appropriate, but that's in your informed consent. You're doing that for this class, right? The risk of diagnosis, what diagnosis is, that you can release that information to the third party. We have a release of information to say we're going to have to release this to your insurance company and or the third party payer if they need it. We don't have to do that with a lot of them, but just insurance really, and making sure that we know how to do this and have the skills to do it. There are always risks, and this is what needs to go in your informed consent. In fact, you could use this slide to put it in that category. You could kind of rewrite these bullet points for your project. They can be stigmatizing. I mean, if I'm going to give somebody a diagnosis that has a stigma, like borderline personality disorder, I better be ready for what that could mean for the person. Um, it is not consistent with a holistic developmental approach, which is wellness and strengths based, which is very much kind of my philosophy. It's historical and socially constructed. It's not an absolute, and it can really pathologize clients. I just said borderline, so people can start to see them as their condition and not as a person. I've had so much success treating symptomology for personality disorders and other issues. I very much hesitate to do a diagnosis such as that, and that is just because they have so many other diagnoses sometimes when they have that I can go with something else and validate it, right? Depression and anxiety. I mean, most people meet a severe score when they come in for that, or a moderate score enough to give them, they have enough symptoms, they meet the criteria in the DSM-5. So, you know, um, that's severe. You're going to see this more in your community mental health agencies. Schizophrenia, I don't treat that because I have no training in severe mental illness. Dr. Powers is our severe mental illness person. She's going to be able to tell you a lot about that. That's someone who needs medicine and severe mental illness counseling, SMI counseling. They need a different type. I am not qualified to do that. Not qualified. Um, because I don't know, I don't have enough training to know what I would do to be effective with them. I also don't have a doc on staff, and med management would be really important with that. Okay, I'm drinking coffee. My coffee break. Drink your coffee. Take a breath. Breathe it out. I know it's a lot of information, but you got this. Remember, this is introduction. I'm introducing everything to you. And then you're going to have a class on everything I introduced, a whole semester on this. So don't stress. This is really just so you're not in shock when you get to the class and you know, hey, this is what I'm going to be learning about. It's really important just to get, kind of start dipping your toe in the pond here. Okay. It can sometimes have an impact on these are more risk about insurance. If you have that and then trying to get insured again, employment. Um, we now um, we use DSM-5 and ICD-10 medical codes, and you diagnose with both, and that's a new thing, and that's been in the past couple of years. And you got to be really sure that you look at the client and not at the diagnosis, right? But there's a huge stigma, and people can be really nervous about it. And coming into therapy can be really nerve-wracking for them because of that. We're seeing less and less of that now, but it can be a problem for people in the military and different jobs for which, if you get a diagnosis that can be problematic for their job, you just have to be really careful. And you guys can't bill until your LPC, so you got plenty of time to learn about all this. You can't bill. I mean, you can't bill insurance, but you can get paid through third-party payers other than insurance before LPC. So DSM-5, that's the purple book that we use to conceptualize cases and find out to look at the case and figure out what the diagnosis is. You're going to look at all the different parts, right? You're going to look at do assessments. You're going to look at them in the DSM-5, and you're going to see how they meet that. And that this looks like a direct quote from DSM-5 there. We should be trained to work with all the disorders. We should be trained on all the diagnoses, but we're not necessarily trained to work with everything. Like I'm not with schizophrenia. We must master DSM terminology and differential diagnosis, and you're going to learn all of that in your class with Dr. Powers. So here are the categories in the DSM-5, and I'm not going to read that to you. Just read those. No, you don't have to memorize them, but just this, so you know what they are. You're going to have that class next semester. And how do you use it? This is the way that you utilize the DSM-5. It's a single diagnostic recording system. Mental health disorders, medical conditions, and psychosocial or environmental issues are listed on one axis, so there's different axes. Principal diagnosis is listed first, followed by other mental health disorders. Medical conditions are listed next, followed by other conditions that may be a focus of counseling, which are Z codes. It's a dimensional approach to diagnosis. DSM-5 has added many specifiers to several disorders to enhance the utility of diagnosis, severity, frequency, duration, and now we align with ICD-10 and ICD-10 codes, which are medical codes. So in the old DSM-4, we used to have an axis. So each axis had, you wrote something next to it, and now it's not like that. That's gone. So please make sure you read 145 and just start to understand what the 4 was like and how it switched to the 5. We used to give people a GAF score, which is a global assessment of functioning, like we gave them a number, and that's gone away, but it looks like research is being done to see if we should bring that back. But anywho, for right now, this is very different. You look at the mental disorder in severity in a continuum of behavior. It's done in a spectrum approach because, as we know, all mental health issues are spectrum, meaning mild, moderate, severe. Everybody looks different. That's what I just said. Mild, moderate, severe. But see, they may have generalized anxiety disorder, but it may be mild, moderate, or severe. There's specifiers that you add to the diagnosis. Those specifiers are the following: the course, so are we in remission? Severity, mild, moderate, severe. Frequency, daily, a few times a week. Duration, minimum, how long has it been going on? And descriptive features with minimal insight, right? What are the features of what's going on? Now we're aligned and harmonized with ICD-10 codes, and that clarifies the diagnosis. So for major depressive disorder, you see how you would code it. F33.2 on page 146, major depressive disorder, recurrent episode severe. F10.10, alcohol use disorder, mild. And Z63.5, disruption of family by separation or divorce. He meets all the criteria for major depressive, and states that alcohol is used to self-medicate. How you record that would be this way. So and you're going to learn how to do that. So you don't need to stress right now, because I know some of you, I can already feel the anxiety even though you've not watched this yet. So just relax, because Dr. Powers is going to teach you exactly how to do this. You will be a whiz when you get finished. And what's going on here? How do you do this? It's a comprehensive part of what we're doing in treatment planning and how we get paid. So Seligman developed a model to help counselors integrate assessment, diagnosis, and treatment planning. The title of this is called Do a Client Map. To do a client map is still relevant. Each letter of the address is one of the areas to be considered during diagnosis. It's a way for you to remember it. Do a client map. So each letter stands for something: diagnosis, objectives of treatment plan, assessment, clinician. So look at that and memorize that. Do a client map model. Because if you remember, this is something that can help you remember what to do. Because it's like, wait a minute, where do I start? What do I do? So, and then make sure you read the case of Javid. I think that might be a good thing to do. All right, psychosocial assessment and diagnosis. It's an approach to what we do that brings in all areas: biology, psychology, social culture factors, wellness, illness. You need to know the principal models and documentation formats of a biopsychosocial case, conceptualization, and treatment planning. You should be skilled at gathering this data. So let's look at this here and make sure you understand what that means. On page 148, you've got the bio, the psycho. The bio is just what it sounds like, right? Biological stuff. So you're going to get this information in your intake packet. This is where you're going to start. This is what I do. I mean, we have a lot of this stuff is in our intake packet. What are you coming in for? The psychological was the history. I get the cognition too. What is their concern? Do they have alcohol issues? What's their mental status? Are they homicidal or suicidal? What's their personal history support system? We do legal, financial. What are the strengths? What are the cultural issues that could influence? What are the, I talked about, I got ahead of myself. Social, what's your work history, education, legal, financial? That's what it is. I mean, it's simpler than it sounds, right? You're going, oh my gosh, biopsychosocial, that sounds really stressful. It's not. You literally could take this and make your intake packet out of it. Suggest maybe you do. What are their goals? Follow their goals to make the plan. What's your diagnostic impression based on the BPS? What are you thinking after you hear it all? Then what? Assessments? Standardized assessments? Then you do something. Then you hypothesize, write up a treatment plan, and you make sure the client's involved in that process. And you did it. You're finished. I'm looking forward to talking with you guys about this. So when we meet.